Hello everyone, welcome to our presentation and thank you for joining us today. This is Amber Rogers and I'm joined today by two of my classmates, Krista Frank and Daniel Crone, who will be presenting a diabetes update for the primary care provider. Information in this presentation will provide a brief overview of the changes made to the 2019 American Diabetes Association Standards of Care.
The learning objectives for this presentation include participants will apply American Diabetes Association 2019 Standards of Care updates to practice problems. Participants will recognize classifications of diabetes. Participants will identify at least one appropriate utilization for telemedicine in diagnosing, assessing, and treating diabetic patients. Participants will identify the proper population to be screened for new development of diabetes. Participants will be able to select appropriate second-line medication therapy in diabetes patients that have established cardiovascular disease, heart failure, or chronic kidney disease. And participants will be able to select at least one positive, non-judgmental example of language to use in their practice to promote empowerment in patients with diabetes.
Every February, the American Diabetes Association releases new recommendations regarding the standards of medical care for patients with diabetes. These recommendations are patient-centered and they focus on the national goals and guidelines to give providers robust evidence that can be applied to clinical practice. Now, the standards of care is 183 pages long, so this presentation will focus on the most impressive changes that were made to the standards of care that are worth noting for primary care providers. We also felt compelled to include a brief overview of some of the things that have not changed in diabetes, such as etiology, risk, and pathophysiology, in an effort to give the learner a more comprehensive picture of diabetes that will ultimately lead to improved patient care and treatment. So to begin, I want to turn the presentation over to Danielle, who will provide us with an overview of the etiology, risk factors, pathophysiology, and diagnostic criteria related to diabetes.
The exact cause of type 1 diabetes is unknown. What is understood is that the body's own immune system attacks the insulin-producing cells of the pancreas. It is believed that the immune system is triggered by genetics, environmental factors, and/or exposures to viruses. The known risk factors for the development of type 1 diabetes include family history, genetics, and age. A person with a parent or sibling with type 1 diabetes is at an increased risk for developing it themselves. Type 1 diabetes can occur at any age. However, the more common occurrence is in children. Additionally, there are certain genes that increase the risk. The exact etiology of type 2 diabetes is also unknown. However, there are multiple contributing factors. Some of these risk factors are modifiable, including obesity, physical inactivity, smoking, and alcohol abuse. Non-modifiable risk factors are ethnicity, age, and family history. Type 2 diabetes is more common in Native Americans, Black Americans, Hispanics, Asian Americans, and Pacific Islanders. The risk also increases in people aged 45 and older. Additionally, people who have a first-degree relative with type 2 diabetes has a 40% chance of developing diabetes themselves. People with hypertension, dyslipidemia, polycystic ovary syndrome, and gestational diabetes are also at an increased risk for the development of type 2 diabetes. Gestational diabetes is caused by the normal changes in the body that occur during pregnancy. The placenta produces a wide range of hormones that impair the action of insulin in the woman's cells, raising the blood sugar. As the baby and placenta continue to grow, the hormones also increase, further counteracting the insulin. Risk factors for gestational diabetes include ethnicity, age, family history, personal history, and weight. Women who are over the age of 25 are at an increased risk for gestational diabetes. Additionally, if there is a family history, or if a woman has been diagnosed with gestational diabetes previously, or has type 2 diabetes, then she is more likely to develop gestational diabetes. Women who are Asian, American Indian, Black, or Hispanic are also at an increased risk. Lastly, women are at an increased risk for gestational diabetes when they are overweight, with a body mass index greater than 30. The pathophysiology of type 1 diabetes involves the autoimmune destruction of the insulin-producing beta cells in the pancreas. The cause of the destruction is not completely understood. However, it is thought to involve genetic and environmental factors. Once the beta cells are destroyed, the pancreas produces little to no insulin, leading to elevated blood sugars. Type 1 diabetes can occur at any age, not just in children. Type 2 diabetes includes increased insulin resistance and impaired insulin secretion by the beta cells of the pancreas. Beta cells in the pancreas are responsible for making and releasing insulin when they sense a rise in blood glucose levels. In insulin resistance, the cells of the body are unable to use the insulin hormone, thus inhibiting their ability to absorb and metabolize glucose. Normally, insulin assists with the cellular uptake of glucose, so without insulin, glucose remains in the bloodstream, resulting in hyperglycemia. In response to the hyperglycemia, the beta cells produce more insulin. Over time, the beta cells begin to get tired due to the overproduction and eventually stop producing insulin. Gestational diabetes is any degree of glucose intolerance that is diagnosed in the second or third trimester of pregnancy. During pregnancy, the body produces multiple hormones that impair the normal actions of insulin, leading to high levels of blood glucose. As the pregnancy progresses to the second and third trimester, there is a surge in these hormones that contributes to insulin resistance. If the pancreas is unable to produce enough insulin to overcome the effects of these pregnancy hormones, gestational diabetes results. Diabetes can be diagnosed using 3 different tests. The first test is the fasting plasma glucose. This test requires that the patient not have had any caloric intake for at least 8 hours. The second test is the 2-hour plasma glucose during an oral glucose tolerance test. The patient is asked to drink a solution containing 75 grams of sugar, and 2 hours later the patient's blood sugar is drawn. The third test is the hemoglobin A1C. This test is an indirect measure of the average blood sugars over the previous 3 months. In order to confirm a diagnosis of diabetes, there must be 2 abnormal results from the same sample or in 2 separate test samples. With type 1 diabetes, plasma glucose rather than an A1C should be used to diagnose acute onset, as type 1 onset is rapid and the A1C may underestimate the hyperglycemia. Autoantibodies, including the GAD and isolate cells, should also be drawn. 2 or more positive antibodies will confirm a type 1 diabetes diagnosis. Conditions that affect the red blood cell may result in an inaccurate A1C. These include conditions with a high red blood cell turnover, such as with sickle cell or pregnancy. Also, persons requiring a blood transfusion, erythropoietin injections, or patients on hemodialysis require a plasma blood glucose to diagnose diabetes, as the A1C may be falsely low. Gestational diabetes is diagnosed with either the 1-step or 2-step oral glucose tolerance test in patients who are at average risk for gestational diabetes between 24 and 28 weeks of pregnancy. The 1-step test requires that the patient has been fasting for at least 8 hours. The patient is then asked to drink a 75-gram glucose drink, and her blood sugar is checked after 1 hour and then again after 2 hours. Gestational diabetes is diagnosed if the fasting blood glucose is greater than or equal to 92. The 1 hour is greater than or equal to 180, or the 2 hours is greater than or equal to 153. The 2-step approach requires that the patient drink a 50-gram glucose drink and then have her blood glucose drawn after 1 hour. If the plasma glucose level measures greater than 130, 135, or 140, then the patient requires a 100-gram oral glucose tolerance test. The patient must be fasting for at least 8 hours. Her fasting blood glucose is drawn, then she is asked to drink a 100-gram glucose solution, and her blood glucose is drawn at 1 hour, 2 hours, and 3 hours. Gestational diabetes is diagnosed when at least 2 of these values are abnormal. The American Diabetes Association recommends that a hemoglobin A1C test should be routinely assessed on patients who have diabetes. The A1C test reflects average glucose levels over a period of 3 months. The test also has a strong predictive value for diabetes complications. A reasonable goal for patients who are not pregnant is less than 7%. However, providers must also consider each patient individually. A more stringent value, such as 6.5% or less, may be recommended for patients who have a long life expectancy, no significant cardiovascular disease, and won't experience significant hypoglycemia. Less stringent controls, such as less than 8%, could benefit patients who have a history of severe hypoglycemia, a limited life expectancy, extensive comorbid conditions, or advanced microvascular or macrovascular complications. Providers must also consider elderly, children, adolescents, and pregnant patients when setting glycemic targets, as each of these populations will require different hemoglobin A1C targets. Additionally, providers should recognize that patients' glycemic targets will change with time. Glucometers should not be used in community screening events to diagnose diabetes. There can be as much as 20% difference in glucose readings between each meter. The ADA recommends using this screening tool to identify those at risk and promote behavior change. Although it seems logical to screen asymptomatic patients for diabetes and prediabetes, clinical studies have indicated there is no benefit in screening the asymptomatic individual. However, age and being overweight pose a major risk factor for developing diabetes. Patients older than 45 years of age should be tested, and patients at any age that are overweight or obese and have one or more risk factors for diabetes should be tested.
Standard 4 focuses on the comprehensive medical evaluation and assessment of comorbidities. A new recommendation to this section is the added text that guides healthcare professionals to be more cognizant of the language that's used to communicate with patients that have diabetes. The use of patient-centered language and communication will energize the patient into believing in themselves and caring for their disease. Also new to this section is the increased emphasis that it takes a healthcare team of professionals working together with the patient to develop a treatment plan. This recommendation has an extensive list of key members of the healthcare team, some of which include providers, nurses, dietitians, podiatrists, and mental health professionals. As providers, we need to take into account all circumstances surrounding the patient's life and help identify and address barriers that may be keeping them from attaining a high quality of life. This is easily accomplished by having several team members working on the treatment plan. In addition, it is important to make sure we integrate the medical evaluation and address lifestyle changes into that plan. The ADA suggests that providers really focus on using language that is non-judgmental, neutral, and stigma-free. The language we should use should foster hope and collaboration between the patient and the provider. We should not use language that fosters shame and blame onto the patient. This slide offers some examples of problematic language that is used and how best to modify the language so that it is patient-centered and non-judgmental. The first column on the right identifies the word diabetic as problematic. Diabetic is an adjective that should not be used to describe the patient. The example given is the diabetic patient, or asking the question, how long have you been diabetic? Instead, place the patient first by referring to him or her as a patient with diabetes and asking the question, how long have you had diabetes? Other problematic terms are use of the word compliant versus non-compliant and adherent versus non-adherent. These terms compliance and adherence imply what someone else wants and suggest the patient is taking orders about his or her care. Remember, diabetes care involves making treatment decisions with the patient. Instead of saying the patient is non-compliant with his or her insulin, describe what barriers exist that prevents the patient from taking insulin. So correct language and documentation may say, the patient takes insulin when she can afford it. Finally, the terms uncontrolled and poorly controlled are often used in clinical practice and should be avoided. Instead, describe what good control looks like. Remember, targets and goals for each patient should be individualized. Therefore, use facts to define what good control or poor control means. So you may document, the patient is taking metformin and a Lantus injection every evening. However, fasting blood sugar trends remain outside the patient's target goal of less than 130. The overall goal in treatment for diabetes is to prevent or delay complications and optimize quality of life. So this is a new graphic called the Decision Cycle for Patient-Centered Glycemic Management in Type 2 Diabetes. The graphic takes us through the steps to reaching patient goals and achieving a mutual management plan. We start on the right side of the graphic, assessing their current lifestyle, comorbidities, and even how motivated the patient is to make changes. Next, we want to take into consideration specific factors that can impact our choice of treatment and consider questions such as how aggressive should we be in lowering this patient's A1C? Can the patient comply with the complicated insulin regimen? Or what's an appropriate A1C target for this patient? Can the patient even afford the medications we are prescribing? Next, there's a shared decision-making involving the patient and family, and an agreement on the management plan is reached. Once that plan is reached, we need to encourage the patient to set a SMART goal. This is a goal that is specific, measurable, achievable, realistic, and time-limited. The ADA recommends that patients not meeting their goals should be seen every 3 months by their provider. In between times, they can have more frequent contact with their certified diabetic educator and dietitian to make sure that they are progressing. The team can offer ongoing support and monitor emotional well-being, tolerance of medications, blood glucose trends, and weight loss. Finally, the ADA encourages us to review the management plan at least once or twice a year to ensure the patient and the interdisciplinary team is still on board with the current plan and that the goals are being achieved. Next, the ADA took time to outline what should be included in the initial comprehensive medical evaluation. First, we need to confirm and classify the diabetes diagnosis. Is the patient type 1 or type 2? Next, we need to evaluate for the complications and existing comorbidities. We are also going to look, what's the treatment plan and is it working? From there, we can begin to talking with the patient and develop a plan and a continuing plan of care. The overall goal for the medical evaluation is to prioritize components given the available resources and time. As a provider in primary care, you may only have 15 minutes to talk with the patient versus the diabetic educator who may spend an hour with the patient. Therefore, it's important that each discipline prioritize what's most important. Some of the topics may include diabetes management, nutrition, psychosocial health, risk for complications, immunizations, sleep habits, and the list goes on. So sometimes it's helpful to ask the patient, what are you concerned most about today? Once that's been determined, the topic may be addressed. Additional topics can be reviewed at a follow-up appointments, and a referral can be made to members of your healthcare team to ensure that the patient receives a comprehensive evaluation. Immunization should also be addressed. We want to make sure that each patient with diabetes receives the influenza vaccine yearly, and this can start as early as 6 months of age. Also, patients need the hepatitis B vaccine starting at age 19. We are seeing an increased risk of hepatitis B due to patients using their lancing devices to check other people's blood sugars. So we need to be sure to educate patients not to check anyone else's blood sugar to reduce the risk of exposure to hepatitis B. And then according to the ADA, the pneumonia vaccine, the pneumococcal conjugate 13 or Prevnar 13 should be given to all patients before reaching the age of 2. Adults 2 to 65 years should receive the pneumococcal polysaccharide vaccine 23. And then adults over the age of 65 and older require the additional Pneumovax 23 regardless of vaccination history. It is important to note that the ADA standards don't mention giving the additional PCV 13 for adults, but the CDC does recommend giving PCV 13 for those at highest risk. The ADA provides this chart in the standards of care that shows the components of a comprehensive diabetes medical evaluation at the initial visit, follow-up visits, and annual visits. Providers can use this as a checklist to help guide the patient's care. A new section seen in the orange on this slide is labeled technology use. Now, this section has been added to assess if the patient is connected to online education and patient portals, as well as to assess continuous glucose monitoring results and insulin pump usage. Another important addition is under the gray colored section on this screening discussing hypoglycemia. The ADA recommends care providers assess for the presence of hypoglycemia, timing of episodes, awareness, frequency, and causes at every encounter. The checklist continues on this slide and offers new recommendations to assess liver function tests at the initial visit and annually. The ADA also recommends that any patient with prediabetes or type 2 diabetes with elevated liver enzymes or fatty liver on ultrasound be evaluated for non-alcoholic steatohepatitis and liver fibrosis by a liver specialist. Also new is assessing for atherosclerotic cardiovascular disease and the staging of chronic kidney disease.
The ADA suggests that lifestyle management is a fundamental aspect of diabetes care. Lifestyle management includes diabetes self-management education, nutrition therapy, physical activity, smoking cessation if necessary, and addressing psychosocial issues for the diabetic patient. Education is key in providing care for the diabetic patient. Diabetes self-management education, or DSME, improves patient knowledge, self-care, lowers A1C, as well as reduces mortality risk. DSME also increases use of preventative services. DSME should be patient-centered, should use appropriate technology, and should be communicated with the entire diabetes care team that the patient utilizes. There are 4 critical times to assess patients for educational needs, which are at the time of diagnosis, annually, any time when compliance issues may arise, and at care transition times. Notably, diabetes self-management education improves outcomes and increases reimbursement. Nutrition is such an important topic for diabetes and an important topic for education due to the incredible amount of information out there and the changes that are made to recommendations. The ADA is suggesting individualized nutrition management for patients. What does that mean? It means that the goals of each patient may vary, and the nutrition management should vary as well. If you have a non-obese diabetic patient, their nutrition should certainly differ from a patient with diabetes who is also obese. We can't provide a routine carbohydrate amount or protein amount for the 2 patients and have great outcomes for both. Glycemic control, weight, activity level, and other factors need to be taken into consideration to appropriately advise diabetic patients on nutrition. Focus on appropriate macronutrient intake is ideal. Patients should choose nutrient-dense, high-fiber carbohydrate options, can do carb counting, or utilize a fixed amount of intake. Any of those might be appropriate for different patients. Avoidance of non-nutritive sugars, including beverages, is a new recommendation. Protein increases insulin response without raising glucose. Therefore, if avoiding hypoglycemia, this should be taken into consideration. Fats are necessary and good fats are ideal, with monounsaturated and polyunsaturated fats being suggested, which are part of the Mediterranean diet. Eating long-chain N3 fatty acids reduces cardiovascular risk and can be found in nuts, seeds, and fish. The ADA does not, however, recommend supplements. Avoid use of alcohol. Alcohol use increases the risk of hypoglycemia. Notably, sodium consumption should be part of education, but only as noting to keep intake at the normal 2,300 milligrams per day or under, which is the recommendation for both patients who have diabetes and who do not. Keeping information educationally appropriate and as simple as possible can be helpful. Exercise should be part of the lifestyle for all patients, including those with diabetes. Adults with type 1 or 2 diabetes need at least 150 minutes per week of moderate to vigorous exercise. This can be spread between 3 days without more than 2 consecutive days not exercising. Routines that focus on flexibility are great, especially for the elderly. Muscle, strength, and resistance training are important 2 to 3 times per week on non-consecutive days for those able. Avoiding the sedentary lifestyle is important in glucose reduction. Patients should try to stay active throughout the day and get up from sitting at least every 30 minutes. Nutrition is an important topic for diabetes. Smoking cessation should be a priority for any patient with diabetes who smokes or uses tobacco products, including e-cigarettes. Assessment for both use of tobacco and need for cessation should be done at every visit. The new recommendations from the ADA highlight including e-cigs in part of the tobacco cessation. Patients should be monitored routinely for mental health and psychosocial issues that may arise. Stress related to diabetes, diagnosis, expectation of care, mood change, quality of life, financial issues, and social issues should be assessed at each visit. Patients 65 or older should be assessed routinely for cognitive impairment and depression. Patients should be monitored for diabetes distress, especially when goals are not met or complications arise. Diabetes distress refers to significant negative psychological reactions related to emotional burdens and worries specific to an individual's experience in having to manage a severe, complicated, and demanding chronic disease such as diabetes.
Section 7 is a new section in the Diabetes Standards of Care, and it discusses diabetes technology. Diabetes technology is used to describe the hardware, devices, and software that people with diabetes use to help manage blood sugar levels, stave off diabetes complications, reduce the burden of living with diabetes, and improve their quality of life. Technology will continue to change the way diabetes is managed by patients and providers in the future. As you can see from the picture, diabetes has advanced to the point that patients are able to view their real-time blood glucose values on their insulin pump, allowing patients to deliver insulin and respond to extreme high blood sugars or intervene in times of low blood sugars. Diabetes technology allows for several options for insulin delivery, including insulin syringes, pumps, and patches. Insulin therapy is available to patients of all ages. However, pump therapy does have its drawbacks. The insulin pump site can become dislodged or the tubing occluded, which causes the patient to enter a state of absolute insulin deficiency, increasing the risk for diabetic ketoacidosis. Also, lipohypertrophy, or the frequent lumps and scar tissue under the skin, can develop from the overuse of injections in one area. The lumps will feel hard to the touch, and the patient will experience less insulin absorption if insulin is injected into this area. This is one reason why it's very important for us to encourage patients to rotate their injection sites and prevent lipohypertrophy. Finally, patients can develop infections at the site of their insulin pump, so always educate the patient on the importance of good hand washing and cleansing the skin with alcohol prior to insulin pump insertion. Diabetes technology also offers several options for glucose testing. There are numerous glucometers on the market, and as previously mentioned, some patients may qualify for the use of the continuous glucose monitor. The latest development is the flash glucometer, where a patient wears a sensor that will read blood sugars. The patient flashes a handheld remote over the sensor and obtains a glucose reading, avoiding the need for finger sticks. Continuous glucose monitoring uses interstitial glucose, which correlates nicely with the plasma glucose, offering real-time blood sugar readings. The use of CGMs over glucometers were shown to reduce A1C levels by 0.6% and offered less blood glucose variability and more increased time within blood glucose target range. The continuous monitor has alarms that can be set to alert patients of low or high blood sugars. So these alerts are particularly beneficial to patients who have hypoglycemia and awareness and no longer feel the signs and symptoms of when the blood sugar is getting critically low. The most recent advancements in pump therapy allows the sensor to augment with the insulin pump and stop insulin delivery during times of hypoglycemia. For example, if the patient's blood sugar trends were rapidly falling and measuring less than 70, the pump would suspend the insulin and restart once the blood sugars have normalized. As healthcare professionals, we need to be aware that there are certain substances that interfere with the accuracy of the CGM, and there is a nice list of these substances found on 7.2, a table on 7.2, page 75 in the Standards of Care. The most widely used substance that we see is Tylenol, which can cause falsely high glucose readings. In this section, the ADA also discusses glucose monitoring in patients with type 2 diabetes on oral glycemic medications. Interestingly, they report that in people with type 2 diabetes not using insulin, routine glucose monitoring may be of limited additional clinical benefit. So for example, if you have a patient newly diagnosed with type 2 diabetes whose A1C is 7.9, you may prescribe the patient metformin and make a referral to the diabetic educator and dietitian to learn about this chronic condition and be instructed on lifestyle changes. Metformin is a drug that does not cause hypoglycemia, and it may take 4 to 6 weeks to build up in the system to see the lower blood sugar result. In addition, weight loss from lifestyle changes take time, and they will not readily affect blood sugar readings. So this may be a patient that you do not have to check blood sugars daily. On the other hand, if you have a patient with diabetes that is on 3 oral agents, one of which is a sulfonylurea like glimepiride, this class of drugs is known to have cases of hypoglycemia. So this patient, you may find it necessary to check the patient's blood sugars. The ADA really leaves it up to the provider's discretion. So for the newly diagnosed patient with diabetes who's overwhelmed by having to change her eating habits and increase her physical activity, take new prescription medications, being able to eliminate that blood glucose monitoring may be welcomed. Also of note, the picture on this slide shows a flash glucometer. It's also considered known as an intermittent scan continuous glucometer. The patient waves the handheld device over the white center that in this picture is located under the patient's right arm to receive a blood glucose reading. The device will not give the patient alarm or notifications if the blood glucose is dropping below 70 as with the other continuous glucose monitors, but the patient can easily check their glucose level by scanning the sensor. And most of these sensors will last 14 days before having to be replaced. Okay, so next we're going to talk about pharmacological updates, and the 2019 ADA Standards of Care provides a new algorithm for the oral glycemics and the insulin. They offer an increased focus on selecting medications appropriate for patients with diabetes who also have cardiovascular disease or chronic kidney disease. And then also included are some updated charts that consider the cost of medication as well as the adverse effects such as risk of hypoglycemia and weight gain. The ADA takes a stepwise approach to starting pharmacological agents, so I will show you the graph that they use in the book, but first I want to talk through it a little bit. And the first line intervention is unchanged. It's metformin plus lifestyle changes. If after 3 months on this treatment the A1C goal is not met, the patient should be prescribed metformin plus lifestyle plus another agent. And this is where it is new in the algorithm this year with step 2. If the patient has cardiovascular disease, congestive heart failure, or chronic kidney disease, we want to consider the addition of a second agent that shows a reduction in the risk based on the effects of the drug. And so we actually have 2 options. If the patient has any of these conditions, we can try an SGLT2 inhibitor that has been shown to reduce cardiovascular, heart failure, and slow the progression of kidney disease. This class of medications causes the kidney to release glucose through the urine, and then that acts as a diuretic, reducing fluid and overall symptoms of heart failure. There are actually 4 SGLT2 inhibitors in the class, but the 2 that stand out, reduce cardiovascular risk, are listed here and include Jardiance and Invokana. Jardiance has actually been shown to reduce cardiovascular death, all-cause mortality, and heart failure hospitalizations, where Invokana has been more superior to reducing the heart failure hospitalizations. Since these drugs are filtered through the kidneys, we do need to evaluate the GFR. These drugs should not be used in patients that have a GFR chronically below 45. And the main side effect we'll see with these drugs are the genital and urinary tract infections, and there is an increased risk of limb amputation associated with this class. So, as a provider, it may be prudent to conduct a diabetic foot exam and ensure that no skin breakdown or ulcers are found in the lower limbs before starting the patient on this class of medications. The other class that can be used to reduce cardiovascular disease is the GLP-1 receptor antagonists, and there are five drugs within this class, but the two that have been superior in cardiovascular risk reduction include Victoza and Ozempic. The main side effect of this class involves nausea, and there is a risk of pancreatitis. And you should know that this drug is contraindicated in patients with a personal or family history of thyroid cancer or multiple endocrine neoplasm syndrome type 2. So you can choose either the SGLT2 or the GLP-1 in step 2. After 3 months, you'll reevaluate the A1C, and if your goal is still not achieved, you can combine metformin plus 2 oral agents. Again, you'll want to reevaluate in 3 months. And then step 4, finally, if your A1C is still not achieved, you may consider starting the injectables, which would be your basal insulin, or you can start your GLP-1 if you've not started that yet. This is the ADA algorithm that you'll find in the standards of care. And you can see at the top, the dark blue, that the first line therapy is metformin and lifestyle changes. From there, if your patient is not meeting their A1C goal in 3 months, the ADA wants you to decide whether the patient has established atherosclerotic cardiovascular disease or chronic kidney disease. If the patient has neither, you can follow the arrow indicating no, and you can choose the agents that is best for your patient. If you're most concerned about minimizing hypoglycemia, you'll want to select an agent from the yellow section in the middle. And if your biggest concern is preventing weight gain and promoting that weight loss, the light blue section can be consulted. You can see that the SGLT2 agent and the GLP-1 agent is found in both the blue and yellow sections and deemed appropriate use to minimize hypoglycemia and promote weight loss. But what if your patient does have those established atherosclerotic heart disease and chronic kidney disease? Then you will need to follow the algorithm on the left-hand side of the page. And first you'll determine if the patient has predominantly atherosclerotic heart disease or chronic kidney disease and heart failure. If your patient is predominantly suffering from atherosclerotic cardiovascular disease, you'll follow the recommendations in the dark blue box and begin that GLP-1 with the proven cardiac benefit, or a GLP-2 with proven cardiac benefit if the GFR is adequate. If the patient predominantly suffers from chronic kidney disease or heart failure, you'll follow the recommendations in the red box. It's preferred that these patients start on the SGLT2 inhibitor with proven benefit. However, if their GFR is less than 45 and contraindicated, they do ask that you consider using the GLP-1. Also, it's important to note that on this algorithm is on the far right-hand side, there is a light green box that recommends certain agents that can be used if cost is an issue. And you can see that those GLP-1 and SGLT2 agents are not listed in this section. Unfortunately, these drugs are fairly expensive, and your sulfonylureas and TZDs remain the least expensive option for your patient. The ADA also provides an additional algorithm to follow once insulin therapy has been started. It did not change from previous years, but I would encourage providers to print out both algorithms and be familiar with the stepwise approach. The insulin algorithm does provide recommendations on basal insulin dosing based on the patient's weight, and also offers suggestions with the titration of insulin to achieve blood glucose goals.
Cardiovascular disease and risk are undoubtedly one of the most common topics when discussing diabetes. Atherosclerotic cardiovascular disease, or ASCVD, is the leading cause of morbidity and mortality among those with diabetes. Additionally, heart failure is another prominent cause of disability and death among those with diabetes. The risk factors are listed above. What do these risk factors actually increase the risk of? myocardial infarction, stroke, peripheral vascular disease, and heart failure. How do we properly assess a patient for their heart disease risk and treat the contributing factors? These are paramount in preventing future cardiac events for the diabetic patient. The ADA standard of care suggests the utilization of the ASCVD 10-year risk calculator endorsed by the ACC-AHA. This can be found online at the ACC-AHA website and is extremely simple to complete once you have patient information. You're asked to add in information about ethnicity, gender, age, blood pressure, lipid findings, statin use, aspirin use, blood pressure control medications, diabetes status, and smoking status. The program automatically calculates the percentage for you, and you can see the likelihood of a cardiac event for that patient in the next 10 years. The information you are provided can guide you in care for that specific patient based on their risk. Lipid control is important in the diabetic patient, as it is in the non-diabetic population, to reduce risk of ASCVD. All diabetic patients should be asked to incorporate the listed lifestyle modifications into their routine in efforts to reduce risk based on lipid factors. But in the diabetic population, some aggressive steps are necessary to reduce risk. In diabetic patients who are 40 years and older, even without confirmed ASCVD, preventative lipid therapy is indicated with a moderate dose statin. If confirmed ASCVD, a high-intensity statin is indicated. Lipid monitoring of the diabetic patient should take place at the time of diagnosis, 4 to 12 weeks after initiation of a statin medication, or during dosage adjustments and annually. Blood pressure control in diabetes is also important in reduction of cardiac events. Blood pressure monitoring is an important part of assessment for all patients. All patients with hypertension or diabetes must be assessed at each visit. On the slide, you'll see that you should measure at every visit. If blood pressure is 140 over 90 or more, you need to recheck with another method of measurement and at a second visit. And that would guide you in the algorithm on the next page. And for 160 over 100, they should be started on 2 agents or a combination agent dose, and you will see that on the next page as well. This is an algorithm to guide you in the treatment of confirmed hypertension in people with diabetes. On the left, you'll see for those with the initial blood pressures that are 140 over 90 to 160 over 100. And then on the other side, you'll see BP is greater than or equal to 160 over 100, and you just follow down the algorithm, and it guides you in some place to start treatment with the drug class. Primary prevention for cardiac events for those at an increased risk is the use of aspirin, usually a baby aspirin or 81 milligrams per day. Secondary prevention for those who have heart disease is aspirin, usually 81 milligrams per day. And those with heart disease and aspirin allergies use Plavix, which is 75 milligrams per day. Those who have had acute coronary syndrome need dual antiplatelet therapy. How do we screen diabetic patients? We screen them for cardiovascular disease based on assessment, as you would for any other patient. So if they came in with dyspnea or chest pain, you would need to screen them. Diabetic patients with confirmed heart disease should be started on an ACE or ARB to reduce the risk of cardiovascular events. Beta blockers are recommended for patients who have had an MI for 2 years post-MI at a minimum. Patients with stable CHF and diabetes type 2 can take metformin if their GFR is above 30 milliliters per minute. However, those hospitalized with CHF or unstable CHF should not. Diabetes type 2 patients with confirmed heart disease should be on sodium glucose transporter 2 inhibitors or glucagon-like peptide 1 receptor agonists. So I thought it would be fun to do a case study And if you don't think it's fun, it's still important. So you have an initial visit with Mrs. McCleary. She's 68 years old and has been diagnosed as diabetic. She's not sure how long ago she was diagnosed, but is taking metformin for a couple years. To complete the 10-year ASCVD risk calculation and estimate risk appropriately, what are some other pieces of information you should gather? And I'll just give you a minute to think about that, and then we'll go over it on the next slide. So we already have some information about her. She's female, we have her age, we know she's on metformin, we need her blood pressure, her lipid levels, her cholesterol level, total cholesterol, HDL, her race, or her medication list, because we want to know if she's on hypertension medication or aspirin, and we need to know if she smokes. And those are all in addition to what we've already learned about her. Just for fun, some other things that would be important to do at this visit would be discuss lifestyle changes, evaluate her glycemic control. If you calculated her ASCVD risk and it was above 15%, then we would be concerned about her, and we would want to start, of course, some other medications, probably a high-intensity statin. So we could talk to her about diet based on her individual factors.
There are more than 30 million people in the United States with diabetes. A lot of these people require oral medications and/or insulin to manage their diabetes. The price of insulin continues to rise, tripling in cost from 2002 to 2013. The rising cost of insulin forces people to choose between purchasing their medications or paying for food, rent, or other living expenses. The American Diabetes Association is working to find ways to make insulin more affordable, so that these people do not suffer the health consequences associated with not taking insulin. In 2017, the American Diabetes Association Board of Directors created the Insulin Access and Affordability Working Group to gain a better perspective on insulin cost and strategies to improve insulin affordability. The working group gathered information about insulin costs and conducted meetings with more than 20 stakeholders. These stakeholders were representatives of pharmaceutical manufacturers, wholesalers, pharmacy benefit managers, pharmacies, pharmacists, distributors, health plans, employers, and people with diabetes and their caregivers. The working group concluded that the insulin supply chain is a complex system. There are many transactions that occur between the stakeholders and incentives offered that contribute to the high price of insulin. In order to support patients who need insulin, the working group suggests that providers have discussions with their patients about the cost of insulin and prescribe the lowest price insulin needed to effectively treat the patient. In summary, we have reviewed multiple topics within the Standards of Care for Diabetes update for 2019. We have discussed the importance of this update, the etiology, risk factors, pathophysiology, and diagnostic criteria for type 1, type 2, and gestational diabetes, explain the recommended treatments, including pharmacological interventions for diabetes, and discuss the implications for practice. These updates are critical for primary care providers when caring for their patients with diabetes because they offer the most up-to-date information. Also, these updates are important because they encourage providers to individualize patient interventions. Diabetes will continue to be a critical disease to manage in order to reduce healthcare costs and prevent other health complications. Therefore, it is imperative that providers stay current on the ADA's recommendations.